am I going to kill my patient if I give them fluid?
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
Okay, so you made the diagnosis in your septic patient in 10 minutes. If not, quit being ridiculous, go back and watch the last podcast episode and become 22% more accurate. If you don't know how to do the things we talked about in that episode, then Google it, watch some older podcasts, or go to CaboFest2017.com and come learn with us in Cabo, Mexico in your Speedo, your bikini, your C-string, whatever. Then watch this episode for the next level. Because once you made the diagnosis and are treating the source, you're not actually done in these sick patients. What about fluids? The eternal question. Well, we've got Mike Mallon, his huge brain, and his delicate, dainty hands to explain it.
All right, I want to talk with you guys for a little bit while we're talking about sepsis, about the idea of fluid responsiveness and fluid tolerance, because I think there's a lot of confusion out there regarding which one's which, how do you use it, and more specifically, how do you apply ultrasound to these concepts, which truly I'm not sure we really understand. So let's talk about fluid responsiveness and fluid tolerance. So first off, what is fluid tolerance? I think the best way to describe fluid tolerance is, am I going to kill my patient if I give them fluid? I think the best way to describe fluid responsiveness is, am I going to get an increase in cardiac output of 10 to 15% if I give fluid? All right. Now what we're talking about here is we're talking basically about the Frank-Starling curve. We're asking about what is the physiology of our patient in terms of what's their preload, which is on the bottom of the Frank-Starling curve, and how is it going to affect their cardiac output, which is on the y-axis of the Frank-Starling curve. And you can imagine that our patients are fairly different. We've got some patients that got pretty poor function, right? And then we've got some patients that have actually pretty good function, right? So we've got here our more normal patients, and we've got people who have decreased function here, right? And the question that we're asking ourselves is, at least with fluid responsiveness, is if I give this increase in preload, say of this much, is the cardiac output improvement that I get worth it? Or is it going to be that 10 to 15% that I was hoping to get? Or am I just fluid overloading my patient? And you can see that that's very different depending on whether your patient has a Frank-Starling curve where they're on the flat portion of the curve, or whether they're still on the upward portion of the curve, the sloped portion of the curve, like we see here. Fluid tolerance is asking a very different question. It's not really asking, am I going to get improvement if I give fluid? It's, am I going to hurt somebody if I give them fluid? Like, can I try fluid in this patient? And really, that's the question we're often asking ourselves in the emergency department. It's, if I give this patient, am I really going to hurt them? So instead of actually looking at these specific numbers and trying to say, okay, are we getting a 15% increase in cardiac output? We're really just saying, is my patient on this side of the curve or not? Right? Am I away from that portion of the curve that's now flat where I'm not doing any improvements and I'm only hurting my patient? So we're really just asking a very general question. Could this patient receive fluid and not get hurt? So how do we do that? Well, to talk about fluid tolerance, let's first start off with saying, all right, if I've got patients who are either fluid tolerant or our patient could be fluid intolerant. My fluid tolerant patients are people who are going to have things like, say, a flat IVC. Or maybe they'll have respiratory variation of their IVC that's greater than 50%. I think those patients, it's pretty safe to say, are fluid tolerant. You can try some fluid in those people. So flat IVC. In the same way, a fat IVC, that's somebody that I'm thinking maybe they're not going to be as fluid tolerant. Maybe that's somebody that I need to then go over and start thinking about fluid responsiveness in. And that's kind of how I treat this. I start to ask the question, is the patient fluid tolerant? If all of these signs point towards fluid tolerant, I'm probably just going to try fluid. But if I'm getting a lot of my signs suggesting that they might be fluid intolerant, then I'm going to think about using this more advanced fluid responsiveness evaluation, which we'll talk about more in a minute. Other things I look for fluid tolerance. Well, I'm going to look at the EF, right? So in a patient who is fluid tolerant, they're probably going to be hyperdynamic. Or maybe just normal, right? But I won't see that they've got a reduced EF. Fluid intolerance, a reduced EF is definitely going to make me think this patient might be fluid intolerant. There's somebody who's not going to respond to fluid as well. Does that mean they don't need fluid? Absolutely not. These patients still probably need fluid, and I'm probably going to try a bolus of 500 cc's, but I'm not going to give them that 2-3 liters before I check again. I'm going to go slower. I'm going to give them the fluid and then recheck and then recheck and then recheck. And very quickly, I'll probably make my way over to more advanced techniques over here. Other things. Can't forget B-lines, right? So a lack of B-lines would suggest that your patient is probably fluid tolerant. Just like a patient who has B-lines, that's somebody who's probably already a little volume overloaded. That's somebody who is going to be in the fluid intolerant category, and I'm more likely going to have to make more advanced measures of fluid responsiveness. RV. So an RV should be fairly normal in appearance for fluid tolerant patients. When we start getting patients who have RV dysfunction or dilation or anything abnormal going on with the RV, that's where I'm starting to think this patient may or may not respond to fluids. It gets really complicated when we start seeing patients with severe RV dysfunction. I'll talk about that in a minute separately. And then finally, I want to talk about diastology. So for fluid tolerant patients, I would expect them to have either normal or impaired diastology. For fluid intolerant patients, I would expect their diastology to either be pseudonormal or restrictive. And this becomes really important because I use this even more aggressively than some of these other measures of fluid tolerance. And why is that? Well, let me tell you for a minute. So if we imagine our heart here, right? So we've got this heart. My beautiful drawing. There's your RV here. There's your LV, right? There's your tricuspid valve, mitral valve, right atrium here, and then left atrium here, right? So into our right atrium, this is your IVC and your SVC coming into your right atrium. Those sort of measure our preload, right? So our preload to our right atrium, we think of as sort of an assessment of our IVC. That's how we assess it on ultrasound, right? And you can get really advanced with these ridiculous tables trying to get the actual number for the patient's CVP or their right atrial pressure, which I think is a little ridiculous. I just like to think of it, all right, is it greater than 50% variation or not? So is it less than or greater than 50% variation? That's how I sort of assess preload to the right side of the heart. Now, we sort of stop there a lot, but that's not really fair because we're really only assessing preload to the right side of the heart. And truly, for most of these measures, when we're talking about cardiac output, when we're talking about perfusing organs, we're talking about getting blood volume to our brain, to our kidneys, to our gut. We really should be more interested in the preload to the left side of the heart. So the preload to the left atrium, which is sort of your left atrial pressure, right? Which is also your left ventricular in diastolic pressure, which has also been measured as your pulmonary capillary wedge pressure. Anybody getting any hints here? What we're really talking about is what is the diastolic function of the left side of the heart, because diastology can give us an assessment of what is the preload to the left side of the heart. And remember, when we're talking about diastology, we've got 4 different groups that we can put people in. There's the people with normal filling, there's the people with impaired, there's the people with pseudonormal, and the people with restrictive, right? Normal people are going to have that E wave greater than the A wave, right? That's on our mitral valve inflow, so that's with their pulse wave gate kind of right at the mitral valve leaflets. This is their mitral valve inflow, and then they'll do TDI here. The TDI, the E prime, is going to be greater than the A prime, right? So E prime, A prime, E wave, A wave. Okay. For impaired, now your E wave is less than your A wave because your atria is having to work a little bit harder. Your ventricle doesn't work quite as well. The muscle doesn't relax quite as well. So that E wave is smaller than the A wave. And now, because the muscle's not working as well, your E prime is often going to be smaller than your A prime, right? For pseudonormal, now our E is back greater than our A again, right? Because now we've got an increase in pressure. So there's something that happens here in between impaired and pseudonormal. So these people have increased left ventricular and diastolic pressure. These people have normal, typically, left ventricular and diastolic pressure, right? And then for TDI, again, your E is going to be less than your A prime. And then for restrictive, now your E is way bigger than your A, usually greater than 2 times. And your E prime is going to be super small because your muscles are barely working at all, right? The trick here is that this is a spectrum, okay? Now, once you leave normal, once your muscle's no longer normal, you never really go back to normal. But you can go from impaired, as I give you more fluid, over to restrictive, right? So fluid will get you over to restrictive. And then diuresis will get you from restrictive back over to impaired. So just like I can have patients who come in heart failure who are in pseudonormal or restrictive disease. We diurese them. We get them back over to impaired. In the same principle, as I give patients fluid who are in sepsis, I can send them from impaired over to restrictive. So now how does this matter in sepsis? Well, there's an interesting study that was released by Pittman that basically suggested that patients who have impaired diastolic function have worse mortality, right? So people who have an E less than an A, right? They have an increase in their mortality, all right? And patients who have pseudonormal filling pattern, E greater than A, and then E prime less than A prime, right? Those patients do better. So how do I use this? Well, what'll happen is, as I take these patients who are impaired, right, and I start giving them fluid, they're going to slowly increase that A, right? Because what's happening is I'm increasing the preload to the left side of the heart. And eventually that E will be greater than the A. So why not just take your fluid, you take your patient, and if you're concerned about their fluid tolerance, start watching their diastolic function. So I watch their mitral valve inflow, right? I'll watch this right here and see that they have an E less than an A, right? And I'll give them a liter, right? And then I'll check again, and now their E is almost up to their A, right? And I'll give them another liter, and now their E is at about the level of their A, right? And maybe I'll give them one more liter and just get that E just above the level of the A. And at that point, I know that I've optimized the preload to my left ventricle. I've got them just a little bit fluid overloaded, which is probably where I want these patients and where the data would suggest that these patients do best. It's just a little bit extra fluid. You want to make sure that you're filling the tank. Now keep in mind that as soon as you start that person on pressors, you might have to recheck this, and we might, with pressors, might see them have decrease in preload, and we have to do this process again and give them more fluid again, because this is a dynamic situation, right? The whole trick here is that you can't just use one ultrasound and determine what your patient's fluid balance is and how much fluid you need to give them. You have to do this multiple times. It has to be a fairly regular process. So if we go back to our patients who are fluid tolerant, or at least fairly fluid tolerant, these people over here, right? If we take these patients here, how am I going to treat them? Well, I'm probably going to start off with, I don't know, 2 liters. Maybe I'll give them 3 liters. Depends on how I'm feeling that day. I'm going to give them a significant bolus of fluid, and then I'm going to check again. Now, say after I check them again, they start getting a few things that look more like fluid intolerance, like maybe they've got a fat IVC, or maybe they've developed a couple B lines, right? If that happens, then I'm probably going to go over and start thinking about some more advanced techniques, like fluid responsiveness techniques, to determine whether they need more fluid or whether I need to start pressors on them. If they don't have any of these signs of fluid intolerance, I'm probably just going to keep giving them fluid. Maybe I'll give them another 2 liters, right? So now they've had 4 total liters. And then after that 2 liters, I'll go back and check again and see if they have any of these other findings. Where's their diastolic function? Is their E wave greater than their A wave now? How am I affecting the preload to the left side of their heart? All of those questions become important. As soon as I get to a situation where I have 1 or 2 areas that suggest the patient's no longer fluid tolerant, when there is some suggestion of fluid intolerance, then I'm going to think about going over and doing some more advanced fluid responsiveness techniques. And the things we're talking about here that assess fluid responsiveness are things such as IVC with respiratory variation. Now, this has taken a lot of heat, and I'm not sure exactly how accurate it is. I think the data is all over the place. You got to recognize that if patients breathe harder, there's more respiratory variation. We're talking about patients that are not mechanically ventilated. Now, if your patient's mechanically ventilated, the data is pretty good here. But in the spontaneously breathing patient, the data is still somewhat questionable. But it would suggest that you can have an accuracy of around 80% to assess whether your patient's going to be fluid responsive or not. And there's different cutoffs for that. Some of them say that you have to have an IVC change of greater than 40%. Some say greater than 50%. I just kind of use 50% because it's an easier number for me to remember. I don't necessarily use this as a measure of fluid responsiveness. I feel like if the patient has enough evidence of fluid intolerance, I want something a little bit more accurate than just my IVC. Keep in mind, I do use the IVC over here when I'm assessing for fluid tolerance. Now, things that we can use that are a little bit more accurate but a little bit harder are things like cardiac output. So now we're talking about measuring a VTI at the LVOT. You want to learn more about that, go back and watch our podcast on measuring cardiac output. I'm not going to talk about it right now, but we can do this with either a passive leg raise or with a fluid bolus, right? And this is pretty accurate. This is sort of 90% accurate. Now, that requires that you know what you're doing and you've got some experience with echo. So if you haven't done a bunch of echo, if you haven't done a bunch of pulse wave Doppler, this might not be the thing for you. You might need to practice a little bit more before you pick it up. Another thing is carotid VTI. Right now, we saw a paper by Merrick about this that showed pretty good accuracy using a passive leg raise. You can also do it with a fluid bolus, right? And this is with a change in an increase in carotid flow greater than 20%, says that your patient's going to be fluid responsive. Now, this hasn't really been reproduced. We've only seen it out of one site. It is very interesting. I like it a lot because it's super reproducible. You don't have to get any cardiac windows. The carotid is super easy to see on ultrasound and to reproduce the exact same image. So I am a fan of the carotid VTI, keeping in mind that there's not as much data supporting it. And then, of course, we've got things like we can do pulse pressure. There's stuff that's been around for a long time, doesn't use ultrasound. There's also, of course, NICOM and et cetera, et cetera. So these are harder, right? This is your hard stuff. And I only get to this once I've exhausted my fluid tolerance because this stuff is fairly easy, I think. I mean, granted, I talked about some diastolic function down here, but for the most part, these assessments are fairly reproducible, whereas fluid responsiveness assessments are a little bit more detail-oriented and a little bit harder to do, especially in your critically ill patient, whereas these are, for the most part, fairly straightforward. So what I do is I start with these. I start with my fluid tolerance, and I don't even think about fluid responsiveness until I'm seeing some evidence that my patient is no longer fluid tolerant. In that case, I start thinking about fluid responsiveness. Now, could you just say, treat your patient and that's fluid tolerant with fluid until there's some evidence of fluid intolerance and then switch them over to pressors? Sure. I don't see why not. I mean, it seems totally reasonable that you think you've gotten to a level where you've filled the tank, as long as you keep assessing, right? You keep watching these things as you start pressors. My approach, as I mentioned, is using this diastolic function, evaluating the diastology of the patient, which I assess as the preload to the left ventricle, and getting my E to the level of my A wave. That's been my approach so far. It's been treating me well. Is there any research supporting it? Nope.
All right. Got it? No? All right, we'll watch it again. Seriously, this was some deep stuff. Mike does an incredible job explaining it, but it's not simple. This isn't pattern recognition like pneumothorax or most of the rest of ultrasound, but it can be important. It can make a difference for that next sick patient that comes into your department. So watch it again and learn it. See you next time.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it. Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
They know that I need the right electricity to move my disco feet. They know that I need a rhythm of ecstasy to get the disco feel. Baby, give me the song that keeps rolling all night long until the break of dawn. Baby, give me the one, 'cause we like to get it done before disco light. You know I don't, you know I won't get it down. You seem to wonder how my funky-licious love. You know I don't, you know I won't fail you. Shoes on my feet, move to the pounding beat, unstoppable indeed. Looks I receive, tell me just what you need, a dancing disco dream. Baby, give all you got, cause this isn't good enough. Can't take no fake or love.